Welcome everybody to this conference. I thought I would introduce it by giving you a brief version of a paper which I was invited to give in Australia, which was a New Zealand layman's perspective on prostate cancer. And the New Zealand contingent of speakers made, in my view, a significant contribution. And interestingly, after Professor John Nacey, who's speaking later today, spoke, one of the American experts who was there approached him and said, "You really ought to come and talk to the US Congress and tell them what they ought to be doing for prostate cancer in America, because you're doing it in New Zealand." So we are at an exciting point of time. The various concerns which I mention in the various slides are all the subject of research reports, and they're available if anybody wants them by accessing our website and seeing the conference presentation which I gave last June. 10 years ago, my view is that we were frozen out of the tent. There was not a lot going on in New Zealand in prostate cancer, and New Zealand Prostate Cancer Foundation was pretty much a voice crying in the wilderness. My involvement in governance of PCF started from 2009, and I came on board at an interesting time. I have a wish list of things which I would like to see happening. Awareness programs supported by the Ministry of Health, by primary care professionals, and this is a progress report, the bits in green. This is being developed by the Ministry at present, and one would expect to see implementation commencing within the next 1 to 2 years. My question, which I pose with a degree of diffidence because there may be some primary healthcare professionals present, is will they actually implement what is required? Awareness and quality improvement program work is being led by a committee, a working group of which I'm a member, and our CEO, Graham Woodside, is on a group representing patients. So the foundation is very much involved. One of the things that we desperately need is to eliminate inequalities and inequities, particularly in the Maori and Pacific Island communities, but also in other groups of society, particularly the lower socioeconomic groups, and those who live in remoter and smaller communities. And again, those concerns are validated by research. In my view, those inequities and inequalities are morally, socially, and legally unacceptable. Much work is being done. I hope that we'll see some progress in the next 5 to 10 years. And when I say legally unacceptable, there is a recent Legal Research Foundation report examining New Zealand's compliance with our international obligations in our domestic affairs, and that confirms that those inequities in health exist, not specifically prostate cancer. I'd like to see government funding, and that's of course the taxpayer, of appropriate drugs, and we were involved in the promotion of to Pharmac of funding of Zytiga, which was announced a couple of months ago. And this is a constant and ongoing struggle, and I'm realistic enough, and we all need to be realistic enough to accept that money isn't inexhaustible. I think it's also very important to note that prostate cancer is treated as in a non-partisan way in the political arena, and that's something which I value hugely. Acceptance of the PSA test. As the Select Committee report said, until something better is discovered, this is the best detection tool we have. At present, it is the best means of detecting prostate cancer when it's still likely to be treatable. It's not perfect, but it has similar accuracy to the breast cancer screening. And what I find fascinating is that there are so many GPs out there who will say, "Oh, the PSA test isn't reliable." I'm prepared to bet good money that those same GPs will still send their female patients off for breast cancer screening, and yet the two tests are similar in terms of their unreliability and their reliability. Someday there will be better tests, or a better test, but until then, that's what we've got. And the second bullet point is taken directly from the 2011 Health Select Committee report. So on my wish list of things is that general practitioners know and follow best practice. Some of them don't believe in it, in PSA testing, but if a GP waits until a man presents with symptoms, then that man is, in my view, being sentenced to a probably pretty miserable end of life, and his family are being sentenced to look after him in that process. So ongoing education is required, and I've said publicly on a number of occasions that this foundation will support any man or his family who want to make a complaint to the Health and Disability Commissioner. And a recent report on cancer generally from the Health and Disability Commissioner indicates that all is not well in that particular space. I sometimes wonder whether general practitioners and specialists really understand what it's like being diagnosed. Research establishes that there is significant variability in the information patients receive and in the pathway of care, and there is a need for greater information, increased support, and understandable planning of treatment and care. So medical professionals require ongoing education. I make this further comment not as a reflection on any of the medical professionals attending, but it is interesting that last year we had a number of professionals attending our conference, and this year an increased number again, and we believe that what we're doing is a useful way of reaching out to those medical professionals. But the Midlands Cancer Study, the report that was launched at Parliament at the beginning of May, is a really significant piece of research in terms of how well we are doing in New Zealand in that space. So next on my wish list, we need more impartial but empathetic advice on watchful waiting, active surveillance and treatment options. This slide was written before this week when the Minister issued a press release and the Ministry of Health issued a guidance document on active surveillance, no watchful waiting. But research does identify a lack of information about prognosis, treatment options, ongoing monitoring and likely complications of treatment leading to avoidable distress. And when disease is terminal, some men feel abandoned. And again, this is from the Midlands Research Study report, which was issued in May. So it, I think, is not unreasonable to say that medical professionals require ongoing education. Speedy access to treatment. Access to treatment does vary between the public and private systems. Geographical isolation from available treatment can cause delays, and it can also cause some distortion in the treatment course that a man may choose to follow. I was speaking just this week to a man who's newly diagnosed, lives in Hawke's Bay, and one of the disincentives for him in terms of choosing radiation as a treatment is that that's available in Palmerston North. They have excellent facilities there, but the commitment to be in Palmerston North for that treatment is a significant disincentive compared with other options. But the Ministry of Health Prostate Cancer Awareness Quality Improvement Program action does indicate that we should see some progress, and I would think that that may take some years, so I'm being a bit pessimistic and saying 10 to 15 years. Post-treatment care through medical professionals and effective peer-to-peer support. I've learned over this weekend that our Australian colleagues who are here and from whom you will hear later today are in fact having some research done in this particular issue. Where do men get their information from in terms of prostate cancer awareness, care and treatment? But the lack of follow-up care and advice following treatment features in several recent research reports, and again particularly the Midlands Research Report which came out in May. So again, medical professionals require ongoing education, and again the Ministry of Health AQUIT program is in my view going to make a significant difference, but it may take some time. Better palliative care, the need for improvement has been officially acknowledged, and again the AQUIT program should improve this over the next 5 to 10 years. So my conclusions: within the next 2 to 3 years, New Zealand will have a good framework to address the logistical issues surrounding the provision of consistent high-level medical care and equitable outcomes across the whole prostate cancer pathway. Providing adequate funding and physical and human resources to deliver on the promised improvements will, in my view, be an ongoing challenge. The ethical issues surrounding the provision of that consistent high-level medical care and equitable outcomes may in part be resolved when professionals involved are provided with better information, training and resources. Earlier comment about Professor Nacey being approached by this American indicates we are at the leading edge in terms of what is happening in this area across the world. However, the ethical issues are, in my opinion, likely to be an ongoing problem. My view is that those who fail to provide the most appropriate care must and will be held to account. I just wanted to give you some food for thought. According to attributed quotation from Albert Einstein, insanity is doing the same things over and over and expecting different results. And John Maynard Keynes, who was more known as an economist than anything else, said the difficulty lies not in the new ideas but in escaping from the old ones. So where are we now? In my view, we're inside the tent. Things have changed and are still changing. A full paper setting out my perspective with extracts from the cited published material is available on the Foundation website. So thank you very much for your attention. It now falls upon me to introduce the next speaker, who is the Honourable Annette King.